I just want to bring this to your attention real quickly. Clinical outcomes, Da Vinci versus open in comparison to laparoscopy. Okay, you can look at it 3 different ways. Let's eliminate laparoscopy right now because we both know that laparoscopic surgery is extremely limited. Guys like Dr. Bake, Dr. Bagazi, even Dr. Park out of University of Maryland. I'll bring this to your attention. Yeah, the patient population.
He's doing this?
He is. Absolutely. Right down the street here in California at City of Hope.
Wow, I trained him.
You did?
Yeah.
Well, maybe you
He's a
two
great
should have a
surgeon.
conversation because let me tell you about the work he's doing with the Da Vinci robot. You can see right here, he's able to receive a positive margin rate of 0%. That's the gold standard. Anything less than that,
I would agree.
for my mom, if I sent my mom to Dr. Big, I'd
How
want
many patients was that? 39?
39%, yeah. And this
Yeah,
is the
39.
problem with the data with regards to colorectal malignancy. There's not a lot of strong data out there to support it. But it's growing, and it's making a pretty significant presentation with regards to the value of the Da Vinci
Right.
surgical system. Because again, it's the benefit of open plus minimally invasive, but if you're able to get 0 positive margins, that's the primary goal number 1. So when you complete your total mesorectal excision, and this is what I want to show you real quick, okay? It has to be complete, I imagine, right? Are you doing lymphadenectomy at all when you're down there in the mesorectal?
We've been on the stage of the cancer.
Okay.
We believe it to be an aggressive
Okay.
stage. Yeah, of course, we'll do pelvic lymph node dissection.
But a uniform dissection is the key, correct?
Exactly.
All right. Well, these are samples of specimens taken from a patient done with a Da Vinci total mesorectal excision,
Wow.
and you can see that they're getting both good distal and radial margins there. Okay. And the value behind it, the reason why surgeons are able to do it successfully with the robot, it's because of, again, that value proposition I mentioned before, the endo-wristed instrument. It's literally, doctor, like having your hand inside there. You can't do that with laparoscopic. You like having your hand in there. That's what most
Without a
colorectal
doubt.
surgeons tell us. And what does your hand do for you, other than feel and palpate the tumor?
It helps me retract bowel and
Okay,
expose.
absolutely.
It's a good tool.
Can
my
you
hand, there's nothing better than my hand.
Okay. How about your eyes?
Not a whole lot better than my eyes either.
How about your eyes and your hands together?
That's usually how I do my surgery.
All right, well, that's what the robot's going to be able to do with you as well, because you'll be able to see in high definition 3D, just like you're doing in an open procedure as well. But let's talk about the ergonomics of surgery. I'd like to understand a little bit more. You've been operating for over 20 years now, right?
Yeah.
And I know
I've been doing it a while.
and you're really busy. So I doubt growing your practice is probably something that's all that important to you, or are you talking
No,
about?
I'm way too busy to grow.
All right. But
I'm
you,
busier than I need to be.
and you like what you do?
I do. I wouldn't do anything else.
Would you like to do it for a little bit longer?
As long as I can. As long as I need to.
Because this is one of the benefits of the robot. Have you ever sat down at the robot?
No.
All right.
I don't need to.
Okay. Well, if this is how you operate, as opposed to operating in an open state like this, bent over, trying to see with a partner. Do you operate with a first assistant, your partner, or anybody?
I have fellows.
Okay, so you're working with fellows. I know you're
Mhm.
teaching, but you're actually working. What's that like?
It can be frustrating at times, but they're there to learn. I'm there to teach them.
Right.
That's really what I enjoy doing, just teaching them my technique.
Well, all right. Well, that's good to know, because one of the benefits of the robot, other than sitting down, the robot that you have here at the hospital actually has 2 consoles. So you could be sitting at the robot, speaking and communicating with another fellow at another robot, right at another console, right next to the patient. And one of the benefits of this, again, as surgeons who are older, Dr. Adrian Park at the University of Maryland. I don't know if you know Dr. Park.
I know him
Okay.
very well.
Yeah, he's doing some work with regards to the benefit of the surgeon. Okay, because Dr. Cohen, if you look at it, the adoption of minimally invasive surgery, right? It's clear there's a benefit to a patient as long as you're getting good outcomes, right? But there's a shift in pain with regards to open. The patient receives a lot of that recovery pain that you mentioned. As you go to minimally invasive, who takes on that pain? The surgeon. The learning curve, the limitations, the frustrations, okay? And you want good outcomes. Well, that's what the Da Vinci robot's going to be able to do. It's going to take, again, the best of both, but that pain, you won't have physical pain associated necessarily with the Da Vinci robot. And as you're getting older and on your feet for long cases, which I imagine.
I'm not old. I'm just better.
True, every day. And that's good. And that's what we're trying to do with surgeons like yourself, okay? So you got the ergonomics, you got the clinical outcomes, but let me show you what it actually looks like. Well, laparoscopic low anterior section, 2-dimensional space, operating with straight sticks, very challenging. But you mentioned having your hand in there with your eyes. The Da Vinci robot system, okay, for colorectal low anterior sections, allows you to have 2 instruments, one for retraction, your camera for visualization, and then you can even have a 4th instrument in there for your first assistant, for irrigation, for coagulation. But look how dry that surgical field is too.
Yeah, that's impressive. They're doing that with your system.
Yeah, and I could show you a little bit more if you like, but you had also asked me at the beginning of this conversation who else is doing this.
Mm-hmm.
How about Dr. Fleshman, former president of ASCRS? Do you know him, Jim?
He's colorectal guys, and I know some of them.
Okay. All right, but again, it's the growth, and it's also on an international level. I know you're an internationally known guy. So I've given you a lot of information. I can show you some more videos and go into the data a little bit more, but you got to help me understand what are you thinking right now?
I'm not sure. You know, the way I was trained, everything's done open. That's gold standard. I really don't know how this is going to fit into what I'm doing. I'm as busy as I need to be now.
Okay. So you do see the value that some surgeons are adopting?
Yeah, I can see how some surgeons would adopt this. But
so is it the... Is it...
I don't know if it's going to be better for my patients.
Okay, you don't know if it's going to be better for your patients.
Cancer removal is my number one priority.
Okay. Well, we can go to the data. We can talk about some data some more if you like. And yeah, I sense a little reluctance in your voice too, Dr. Cohen, with regards to maybe adopting a new procedure. This is not laparoscopy we're talking about.
Right.
And you know, I'll show you one slide as far as data, real quickly. And this is pretty compelling. A lot of surgeons who go from open perspective find that they can adopt this procedure pretty easily because of the robots, because of something we call the clinical pathway. And it's a very proven algorithm that's been created by other surgeons who have adopted the robot into their programs, who've gone with minimal laparoscopic experience from open to robotics. We can talk about that. But let's talk about the clinical data, some of the clinical endpoints too. And again, you mentioned Dr. Pagazzi, you know him.
Yeah, very well.
And you trained him.
I did.
What was he like as a fellow?
Arrogant.
Okay.
But he's a good surgeon. He really is. He learned from me, so I guess he came by naturally.
Well, you know, you don't get pears from an apple tree, as my grandmother used to say. So, Dr. Pagazzi, again, he's doing some great work down at City of Hope, down the street in California. Would you be open to a conversation with Dr. Pagazzi?
You know what? I can reach out to him.
Okay.
I'd like to do that.
All right. If you don't mind, can I set that up for you? Because I'd like to kind of understand a little bit more and attend that conversation, because I really want to know a little bit more about you and what's really important to you from a surgical standpoint.
You want to sit in on our phone calls?
Actually, I'd like to set up a face-to-face if that's okay. I'll bring you down there. I mean, I'll take you myself.
You take me?
If you want,
yeah,
I'll do that.
What are we going to see down there?
Well, there's a couple things we can do. We can actually, he's got a dual console at his facility, so you can actually sit at the console during a live procedure.
Really?
I think what would probably be best before we can get there is...
He probably wants me to do that procedure for him.
That might be interesting, too, to have you as his mentor come down. But again, this is about changing patients' lives for the best part. But before we do that, maybe what we should do is even sit down on the robot right here at the hospital. And I can set it up in OR 8 one day, come in and just actually sit at the robot and see what it feels like.
Yeah, I'd like to sit on it first.
Okay, let's do
I've
that.
never seen it, really.
All right, so first things first then. Why don't we sit you down on the robot, see if it's something you like. In the meantime, I'll reach out to Dr. Pagazzi, see if I can facilitate a meeting for you, something simple, maybe even just a conversation. If you want to do a case op, we can do that next. And we can look at some more data as well.
All right. Yeah, I think I could do that.
Does that sound good to you?
That's fine.
Okay.
What day is that?
We can set it up on Tuesday next week.
Tuesday's not going to work for me.
Okay.
I'm in surgery all day.
And I know you're very busy, but I'll tell you what, you got some time at the end of today?
Kids. I got to go pick them up.
I know, I got kids too.
family
How old are your
comes
kids?
first. I got a 14-year-old son and a 17-year-old daughter. So
Wow.
pretty busy with her.
Sure, no doubt.
She got to go off to college.
Now I understand why you want to
Yeah.
extend your career a little bit longer.
Got to send her to college, and the second one's going to have to go one day unless he ends up in jail.
Okay, well, we don't have that. But I can do, why don't I check with your schedule and set something up tomorrow
see
morning?
what you can clear. if I have time, I'll meet you.